much, except for the cancers and the genetic stuff, everything that we've really talked about so far, they've been like underlying concepts and processes that you've had to learn those processes. So now we're starting to stacking up diseases and disorders where it's easier to memorize than having to understand the processes. But having said that, try not to just memorize the words that are on the PowerPoint. Again, a lot of those folks who come see me, a lot of, and y'all know you don't believe it, but most of the test is definitional kinds of stuff. It's like the patient has yada, 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 what is this? And that's just a definition, Or these are the signs and symptoms, what do you think they have? Well, that's kind of a definition. So do take good notes, and we're gonna talk today about respiratory, and we're gonna do a little bit of A&P review, and then we're gonna talk about respiratory failure. When we do that respiratory failure part, we'll talk about why all of these different things happen when a person has respiratory failure. It's going to be real important that you understand those processes. And then after that, it's going to be up to you to figure out, well, what's the difference in respiratory disease A and respiratory disease B. Does that make sense? But you can do this, y'all. You can do it. Hopefully the grades were good today. What do you think about the test? There were not, I didn't put very many questions where you had to pick the IV fluid. Most of it was kind of like definitional, like what happens if you give a hydrostat, if you give a hypotonic fluid or a hypertonic and that kind of thing. So hopefully you did well. So, the very basis of the respiratory system is that it's there to exchange oxygen and CO2, right? We inhale oxygen and we blow off CO2. That's pretty much all there is to it. The oxygen, where it does take place, is around the outside of that alveoli. You can see that little alveolar sac there. And in your alveoli, you have type 1 cells that are responsible for the gas exchange and type 2 that are responsible for surfactant. Surfactant keeps your airways open. It helps open up your airways. Helps keeps your alveoli from collapsing whenever you exhale. And I've got better pictures of the alveoli coming up. There you go. There are these little grape-like clusters, and each one of those little humps there you see, it's like a little ball. It's got a wrapping around every piece of it. So it's all around those little balls where the blood vessels meet there, where the oxygen exchanges places. The reason that that's so important to understand is that if there's a problem down here, if this is sitting underwater, they've got fluid buildup in their lungs, there's not going to be any gas exchange. Does that make sense? And then one of the diseases that we're going to talk about, these tiny little grape-like clusters, lose their inner walls here, and they just are in like a big dilated balloon. So you have to have those little alveoli that can constrict and expand, and they have to have good blood flow there to them. So ventilation is just moving of air in, and perfusion is how much blood is being delivered there at the alveolar space. So perfusion is blood, and then diffusion is the oxygen, how much of the air, the oxygen is moving, and the CO2 is moving back and forth. So you have to have all three of those things to be able to breathe adequately. Good air getting in, good blood flow, good blood supply at the alveoli, and the gases are going to have to not have any impediment to moving back and forth across those alveolar spaces. I'm not really going to go through this with you all, but this is just the pathway from nose to alveoli, where the oxygen flows. So just make sure that you are familiar still with the anatomy. The right lung has more lobes than the left lobe. And the other thing that's important, let me see if I have it on this next PowerPoint. Yeah. Oops. So the right lung sits actually a little bit lower in the chest than the left lobe. That's all there really is to that. Something that is important too, that's important too, but can you see right here, this is your trachea, and this is where your left and right main stem bronchus come off. So the left, it's like a hard 90-degree turn, and you can see on the right that it's kind of straight. right? So let's say you dropped a BB or a marble in somebody's airway. Which lung do you think it's going to go to? The right. It's going to be hard for it to make that hard turn and go to the left. So that's important to know because a lot of pneumonias, when people aspirate, if somebody chokes on something, whenever a person gets intubated, you have to put an airway in them. A lot of times it slips into that right side. So what do you think happens if you put a tube in somebody, you were having to put them on a ventilator to breathe, and the tube goes down here?
You're not going to fill the left.
Right, you're only going to get half the ventilation and gas exchange. Y'all remember what cilia are? It's those little finger-like projections that line your airways, and they are important to help keep things out. You know, you cough, you sneeze, you spit things out. Anything that impairs the ability of your cilia to work is going to increase the likelihood that you may develop some kind of aspiration or pulmonary infection. So really dry air will do that. ETOH is alcohol. Well, I wrote it up there for you. You're going to see that abbreviation a lot if we haven't already been using it. It just means alcohol. Big temperature changes can do it. Very dry air can also cause those cilia not to work well. Don't know what the importance of accessory muscles are yet.
It helps somebody breathe, like when you can use your back to.
Right. So when y'all do your vital signs checkoffs in a few weeks, have y'all already started practicing that or have those lectures yet? Did they tell you? No. They probably, your teachers may tell you you might want to put your hands on the chest of the person who you're trying to count their respiratory rate for, because your chest really doesn't move that much when you sleep. I'm sorry, when you're breathing. It doesn't move that much. I was thinking, it's a story, y'all might not want to know this much about my personal life, but one time I had worked like a double shift and I worked, overnight, and I stayed up and my husband and I went to bed, at dark the next night. And I remember laying there in bed and feeling him put his hands on my throat, seeing if I had a pulse. Because I guess I fell asleep so fast and so hard and he couldn't see my chest. He's not medical, he's an engineer, right? So, but it was just funny, and it's like I could feel him, and he had his hands on my carotid artery. And I was too tired to even say, what are you doing? I mean, I just went to sleep. So it's really hard sometimes to see a person's chest move. So if you see somebody using those accessory muscles, then we're worried that they're having some kind of respiratory distress. And so the big ones are your sternocleidomastoid. I love to say that word. It's a muscle that wraps from your neck around to your breastplate. Your intercostals. People also get nasal flaring, but that's not up there. Then your pecs. I mean, they just don't move that much unless you're having to work really hard to breathe. Your abdominal muscles. So hopefully something else that you remember from probably high school anatomy, and if not there, certainly from Dr. Rodine's anatomy out here, is that in the lungs, that's the only place that veins carry oxygenated blood and arteries carry unoxygenated blood, right? So the pulmonary vein is going to have oxygenated blood, and the pulmonary artery is going to have unoxygenated. So the pulmonary artery comes off of the right ventricle, and then the pulmonary vein comes off the lung and goes back into the heart. For us to be able to breathe, we have to have a working neurological system, right? So that's why individuals, if they have spinal cord injuries, high neck, C1, C2, C3, anything above C5, a lot of times they'll be ventilator dependent for the rest of their life. In your pons or your medulla, you have that respiratory control center of the brain, and it has to be working. Things that can help us control how fast we breathe there are chemical receptors. Next week, the lecture is on acid-base balance, and so you're going to learn more about bicarbonate and hydrogen ions than you probably ever wanted to learn. But that's what the chemical receptors sense. What is the pH in our blood? What is our CO2 levels? Proprioceptors recognize when we're exercising, and that will increase our breathing. Baroreceptors recognize changes in pressure. Now, not atmospheric pressure, like there's a hurricane coming and that barometric pressure's falling off, but this one it's mostly concerned with your blood pressure. So those, all of those triggers are stimulus for us to breathe. Perfusion is the amount of blood that gets into your, into your lungs, but primarily those alveolar spaces, and so it's greatly affected by positioning. If you haven't already, and I don't think y'all done respiratory stuff and skills yet, but you're gonna learn right away that if somebody's having any difficulty breathing, one of the very first things we wanna do is get them upright. Because most of the gas exchange takes place in the bases of your lungs. So if a person's having a difficult time breathing, we wanna at least get them up so that where the gas exchange can take place is being perfused very well. If you're, that's probably a sign it's gonna die really soon if it cut off on its own. So if you're laying down flat in the bed, you're not gonna get as much perfusion as you would if you're sitting up. And then when you exercise, the perfusion should increase as well. The blood vessels, the vascular blood flow through your lungs, it's a low pressure system. So y'all, what's a normal blood pressure?
120/80.
120/80. And you can see that the pressure in your pulmonary space is something like 20/8 or something like that, 22/8. That's measured the same way as blood pressure, so that's the pressure of blood in your lungs. So it is a very, very low pressure system, and if that pressure increases in your lungs, it's going to cause big respiratory problems. So things that can make your blood pressure in your lungs go up would be, what was the condition that was on today's test that would make your pressure in your lungs go up? Edema from fluid volume overload, yeah. So heart failure, kidney failure, renal failure, any of those things that can make you have volume overload can increase the pressure in your lungs. The problem with increasing the pressure in your lungs is that your heart has to squeeze hard enough to get blood in there. And so if you make your the blood pressure really high in your lungs, you're going to make the heart work really, really hard. And it can make the heart fail. The answers were up there, all that fluid's just an edema. So we kind of mentioned this before, but most of the perfusion and exchange of gas is going to be in the bases of your lungs down here. So the farther you go up your lung, the less gas exchange that occurs. Does that make sense? This is also the reason that most like pneumonias and those kinds of things, any kind of pulmonary infection, any collection of fluid, usually are in the bases of your lungs as well. And it's purely gravity and what's being perfused the most. So we're going to talk a little bit about the ventilation perfusion. Now it's represented as a ratio. Y'all know a ratio is just like 2:4 is 4:8. So you can set it up like a fraction, or you can just say it like I just said it. So what the ventilation perfusion ratio is it's an indicator of how much blood is getting to the kidneys and how much, not to the kidneys, how much blood's getting into the lungs and how much blood's getting, and how much air is getting into the lungs. And so it's ventilation is the top number and perfusion is the bottom number. So in a minute's time, we bring in about 4 liters of air. And in a minute's time, about 5 liters of blood circulates through your heart. So 4 liters of air, 5 liters of blood. So if you do the math on that, it's 0.8. The reason that that's important, and I'm hoping it's on this next slide, is that if you have a high or a low ventilation perfusion ratio, that kind of points to what's wrong. It helps us figure out what's wrong with where the problem is. So if we think about that number being a fraction, ventilation over perfusion, how do I make the ventilation, make that number, that 0.8 go up higher? Yeah, I can either increase ventilation or I can decrease the bottom number. So the biggest indicator, the biggest thing that we're concerned about with these VQ ratio, another ventilation perfusion is also abbreviated as VQ. I think it said VQ on the last slide.
Yeah.
Yeah, so VQ and ventilation perfusion, that's the same thing. So if your VQ ratio is elevated, chances are you've got something decreasing the blood flow to your lung, right? If you're dying, and you're not breathing, that ventilation perfusion ratio is not gonna change, right? Because your respiratory rate's gonna be low and your perfusion will be low. But if all of a sudden your VQ ratio gets really high, chances are there's a blood clot that's gone and plugged up some of the blood vessels there that prevents oxygen from being able to get into your airways. So anything that will lower, so to lower that 4/8, I can either increase the bottom number or decrease the top number, right? So things that cause a low VQ perfusion ratio are any kind of respiratory disease. Anything that impairs your ability to get air in. So we're going to talk today about asthma and bronchitis and pneumonia, lung cancer, all those kinds of things. We would expect that the person would have a low VQ ratio. High VQ ratio usually means a pulmonary embolism. And then a shunt means that there's no gas exchange taking place. Usually, if there's a shunt going on, it's probably because the alveoli are covered in water, covered in fluid. Or maybe your lungs have gotten so stiff that they can't. To breathe, you have to be able to collapse your airways, tightly and open them up. So if there's any diseases that are going to cause those airways to stay open, it's called decreased compliance. That's a shunt. That we get shunting of blood flow there. And then y'all know what diffusion is, because we talked about it last week. But diffusion is so if we're talking about gas, oxygen, the O2 is going to diffuse in, and the CO2 will diffuse out in your lungs. If y'all haven't already learned, something that you'll learn really, really quickly is how to do a pulse ox on a person. You put a little thing on their finger, and it tells you the percentage of hemoglobin that's saturated with oxygen in the blood. And we want that number to be high. We want it to be up above 95. But I don't know if you know this or not, but it's only the oxygen that's not bound to the hemoglobin that can get to your tissues. So that oxygen that's stuck on your hemoglobin, that's bound up to it, it doesn't go into your tissues. It has to be released off of your cells. It has to be released off of your hemoglobin and just free flowing in the plasma, the water part of your blood, for any of your organs and tissues to use it. That's the strength of that bond of hemoglobin is called the affinity. So the more the affinity is, the stronger the bond. So if we say that hemoglobin has a very high affinity for oxygen, it means that hemoglobin is holding on to that oxygen and it's not going to give it off very easily. Does that make sense? So affinity is kind of a good thing, but every now and again we need that hemoglobin to loosen up and give us more oxygen available in our bloodstream. So we're going to talk about this thing called the oxyhemoglobin dissociation curve. Next week, you're going to learn, when Dr. Swansea does the acid-base lecture, all these normal values for PaO2 and CO2. They're on this PowerPoint as well, but you're going to go over and over and over and over and over and over them next week, so you'll know them by the time you get to the exam. But we want, so a normal PaO2, and that is, if we were to stick a needle into an artery and draw the blood off and be able to measure the pressure of oxygen in your blood, 80 to 100 is normal. Usually, like I would suspect for everybody in here, except for those folks who kind of have a cold, that your PaO2 right now is probably 98, 97. I mean, 80 is a little bit on the low side. But anyway, 80 to 100 is normal, and that should give you about 95% of your hemoglobin being saturated with oxygen. So what this oxyhemoglobin dissociation curve really shows you is the difference in the affinity, the difference in how tightly hemoglobin is going to hold on to oxygen and how easily it's going to give off oxygen when it's needed. So the red line a couple things that are important to look at. So here's 100% saturation up here. And here's your PaO2, the actual pressure of oxygen in your blood. So once you get about 100 on your the pressure of oxygen, you can't really make it go much higher. We could work somebody's PaO2 up to 200 or 300, but the amount of saturation is not going to change that much. But anyway, if you follow this curve, it's way down here, and that's 60 before it kind of drops. Does that make sense? So as long as you've got about more, as long as you got more than 60% of your hemoglobin saturated with oxygen, you're not going to be in terrible respiratory distress, right? I mean, we need to make sure we know it. When people start getting down here, getting even in the 80s or so, it's starting to drift down, and we're going to start getting these folks on oxygen in the hospital. But once it gets to 60, like, you can die very quickly. I don't remember many direct quotes from when I was in nursing school, but I do remember clearly the teacher saying that a PaO2 of 60 is incompatible with life. So you can't survive with a low saturation, low PaO2 for very long. So if your PaO2 is 60, if something doesn't happen within the next few minutes, then CPR is going to be happening in the next few minutes. So we want to recognize people when they're starting to have issues up here, really kind of in this area, 80 to 90. But if we don't recognize it down here, then we've probably missed the boat on this person. So there's a couple things that make this curve shift. And basically what that means is if it shifts to the right, which is represented by this blue line, it means that we hold on to our oxygen a little bit better. And if it shifts to the left, it means we're giving it up even faster. So there's a couple things that I want you to learn this semester that control that. Not everything on this list, but you want to know what happens, what impact does the pH have, and what impact does the temperature have. So basically, this curve is going to shift in times of high demand. So an elevated temperature is going to cause you to give off your oxygen more quickly. If a person has acidosis, which means they have high hydrogen ions and high CO2, they're going to give off their oxygen more quickly. If they're cold, they're going to hold on to it more tightly. Like you may have heard stories about patients being in operating rooms, and typically the operating rooms are really cold. And that's not really for the comfort of the people who are working in the operating room. It's for helping preserve the oxygenation in a patient when they're, under a controlled stressor. Right? Like, you tend not to think of surgery as a stressor. So if I were to go outside and somebody cut me from stem to stern in the parking lot, we'd think, yeah, that's very stressful. But if you take me out of the operating room and you gas me up and you give me medicine, and I get cut from stem to stern, that's just as stressful as it was being out in the parking lot. But it's just that I don't happen to feel that I'm not quite aware of it. So know what causes those right and left shifts, and what it means if it shifts to the left or if it shifts to the right. And that it's really reflecting the affinity. How strong is the bond between hemoglobin and oxygen? So when we start talking about respiratory disorders, there's really only two things that can happen. You can have overventilation or underventilation. So hypoventilation or hyperventilation. Things that can cause hypoventilation. The big things that cause hypoventilation are that I would say you should be the most concerned about really are things that might suppress your central nervous system, like drugs and alcohol, toxins, poisons, anything that would put pressure on your chest to not allow your chest to rise and fall. Because again, it's that expansion and collapse of the lungs that makes you breathe. Pain, if somebody's had, they've had heart surgery, one of the big things that folks are taught before they go into surgery, they have heart surgery, is that it's going to hurt a lot. You get this pillow to help brace yourself so that you can breathe. And if you have paralysis. So again, back to that person who has a cervical injury or even a head injury, if it impairs the respiratory center, it's going to impair your ability to breathe. Things that can cause hyperventilation, mostly those are going to be, again, some kind of brainstem or head injury. Anything that causes hypermetabolism, hyperventilation, exercise, those kinds of things anxiety will make you hyperventilate. Sepsis, fever, all those things increase your respiratory rate. Does somebody have a question?
No, I was reading.
Okay.
Sorry.
No worries. And then we want to look at the difference in what is hypoxia and what's hypoxemia. So what do you think the difference is? What does emia mean? Blood. So hypoxemia means you've got low oxygen in your blood. Hypoxia means that you have low oxygen at the tissue level. So it stands to reason that if you have hypoxia, you're going to have hypoxemia, right? And hypoxemia should happen before the hypoxia. That's why we check people's O2 sat monitors so frequently, is because we want to make sure they never get if their oxygen saturation's falling off, we hope to catch that before they start having lack of oxygen at the tissues. What do you think happens when you have lack of oxygen in a tissue? The tissue's not going to do very well. There's going to be an inflammatory response, and hopefully that's it. But the tissues might die, right? So we have to keep people oxygenated. These mild, moderate, and severe oxygenation levels, Dr. Swansea's going to have more of her slide again next week. Y'all are going to memorize those forever and always. So 80 to 100 is normal. So if it's 80 to 100, then it's 70 to 79 is mild. That's right. And then 60 to 69 is moderate. And then again, remember, less than 60 is incompatible with life. It's severe hypoxemia. And that hemoglobin, that saturation of hemoglobin, you're getting with a pulse ox. You'll learn, I guess, yes, ma'am?
You said if we have hypoxia, we'll get hypoxia, or the other way around?
Hypoxemia comes before hypoxia. So if you don't have enough blood and enough oxygen in your blood, eventually your tissues are going to get deprived. You're welcome. And that happens pretty quickly. Because, we talked, I think, a little bit about in here before about how do you go about prioritizing its safety, airway, breathing, circulation. So like if somebody chokes on a piece of steak, they're going to get desaturated hypoxia very quickly. Y'all, I must be talking fast. Y'all getting it written down? No. Seems like I'm usually at about the hour mark at this point when we take our first break. Do we need to back up and look at anything? No? Are y'all still awake for a few more minutes sitting in your seat? Okay. We'll talk about respiratory failure maybe and then take a break. So, like we did with those hematological disorders, we talked about what causes all of those different signs and symptoms that get created. And so that's what I want to do here again is talk about why all these things happen. What is acute respiratory failure and why do all the things happen as they do? So then when we start talking about the individual diseases, we won't repeat it every single time. We'll just start running through a laundry list of the signs and symptoms that happen. So if you have respiratory failure, it means that your blood gases are outside of normal range. All those numbers that you had to memorize. And so if you have too much CO2 or not enough oxygen, then you're said to be in respiratory failure. Your pH, your blood pH is going to change with that. And you're going to learn about the relationship between CO2 and acid next week. So anything that impairs your ability to breathe is going to cause respiratory failure. Or if you, and when you fail to breathe, your oxygen levels go down and your CO2 levels go up. That's what hypercapnia is. So if somebody chokes or they're underwater and they can't breathe in air, their oxygen levels are going to fall down and their CO2 levels are going to go up.
Hypercapnia is an elevated CO2. Wait, no. Hypercapnia is breathing too fast. Hypercapnia is too much CO2. Too much CO2, a respiratory, and not breathing enough, they go together. But hypercapnia is too much CO2. Yeah, it's too much CO2. Breathing too fast is tachypnea, hypercapnia. I was thinking of carboxy acid, but hypercapnia is an elevated CO2.
Okay, so
So if you have an elevated CO2 or you have a low oxygen level, those are indicators that you have respiratory failure.
so the breathing too fast and elevated CO2.
So it's the elevated CO2, and you will get an elevated CO2 if you breathe too slow.
Okay, so hypercapnia is breathing too slow.
Hypercapnia is a high CO2.
Okay, high CO2.
High, just means high CO2. Hypercapnia is an elevated carbon dioxide level. And you get that from breathing too slow. We talk a lot about tachypnic, meaning breathing too fast. We don't usually use Brady breathing, we usually just say slow respiratory rate. So if your CO2 is high or your O2 is low, that's what's going to cause the problems with respiratory failure. You can have either or both. And these are the numbers that you're worried about, your CO2, your PaO2 being less than 60, which we've said a bunch of times already, or your carbon dioxide level being above 50. Okay, so lots of things can cause respiratory failure. Respiratory diseases certainly can cause respiratory failure. Trauma to the lungs can cause respiratory failure. Anything that suppresses that respiratory center. In the hospital, you're going to be really concerned about people getting pain medicine, people coming out of surgery, people being admitted that have had some kind of CNS altering, drug or alcohol. So chest trauma, we already said. Pulmonary emboli, pulmonary edema, those are going to be respiratory disorders. You would be able to recognize that easily. Extreme obesity, it's going to have to be extreme, right? Okay, so something that's really important here. Well, so we want you to recognize the condition. So who might be somebody that, what do you think might be a person that might give you as an example? COPD. I'll tell you one of my favorites and one of pretty much everybody's favorites in the College of Nursing is that we're going to tell you they've just come out of surgery, they've been getting a lot of pain medicine, or we just gave the person some Demerol or whatnot. So anything that's going to suppress your respiratory center, it's going to be a big clue to you all that they may have respiratory failure.
Why pain medicine?
Because they decrease your respiratory rate. I have another story to tell y'all.
You get too relaxed.
Well, they suppress your respiratory. Alcohol suppresses your respiratory center. That's why when people drink a lot, they sometimes have to go to the hospital. So let me tell y'all a story that'll help you remember this. And it's funny to me, it might not be funny to y'all, but it's not funny to somebody on the side, but I'll tell you the story. So we were in clinical, I was in clinical with a group of 8 students. There were several males in the students, so the other guys typically are a little bit bigger, broader shoulder, taller, that kind of stuff. And so we had gone into this room, me and the 2 students, in this room with a lady that's about my size, a little lady, and we had to give her some pain medicine to Patho, an abscess in her jaw. And I know y'all don't know about drugs and stuff yet, but so we gave her 4 milligrams of Dilaudid, which is like 40 milligrams of morphine, right? And you would immediately put me in respiratory distress. So this lady had to have already a tolerance, right, to be able to take that. So typically what I do in clinical is one day you do the dressing change and you go with us. So you're giving the pain medicine, you're doing the dressing, setting it up, and then tomorrow we're going to swap because you've seen it being done, you know how to get the med. So we did it the first day, and the student was really nervous and giving it really, really slow, and everything went fine. So the next day we went and we did it, and we did the exact same thing. And so then we left the room, and I was down the hall doing things with other patients, and it was time to leave for the day. And so the student came back to me and said, "Will you put?" I forget what the lady's name is. I'm gonna call her Miss Smith. "Will you come check on Miss Smith? I don't think she's breathing as fast as she was this morning." And so I was like, "Yeah, I'll tell you what, you go get a pulse ox, and I'll go to the room. So I went down there, she really wasn't. Her respiratory rate was like 6, you know, normal is 12. And so, I stayed there with the patient. The student came in. I said, look, go get the nurse that's taking care of her, and I want you to go get all the students and come back to the room. And because I was going to talk to the nurse about, do we give her Narcan or whatever. And so I sat down beside her, and I would wake her up. You can do, it's called a sternal rub. You push real hard into a sternum. If you've got any bit of consciousness about you, it'll wake you up. So I had the pulse ox in my hand, and I'd watch it, and I'd count her respiratory rate, and I'd do this, you know. So she got down as far as breathing like 2 times. And so I told the student, go get all the other students and don't tell them what's going on in this room. So they all came down there. It was time to go, right? So everybody had on their white lab coats. And remember I told you there's several guys in there, so they're really tall people with these white lab coats on. And so I'm like, hey, you know, so, you know, the students, this is Miss Smith. And they're, you know, they say, hey, Miss Smith. And you know, I'm watching her O2 sat. And so I said, y'all notice anything about Miss Smith? You know, she's just scored, right? She's not breathing or anything. And so after a minute, it's not a minute, a few seconds, the student finally says, she's not breathing. And I was like, you're right. So I woke her up, you know. And so the nurse came down. We decided to give the Narcan. So the student stayed in the room to see what happened with the Narcan. So we gave the Narcan and it reverses. Okay, so we gave her the Narcan, and she woke up immediately. She started screaming because she saw all these white figures hovering over her, and she thought she had died and gone to heaven. So that wasn't a good strategy, I guess. But at the time I thought, well, the students are going to learn so much. First, they're going to recognize it's like nobody's waving a flag that says I'm not breathing here. Like you don't notice it right off, and then how fast you wake up from that Narcan. And so then she really had the lights. We had all the lights on in the room, and all these people, and again, especially these big guys who are towering over the bed, in their white coats with these bright lights in their eyes. And she goes from being, you know, almost dead to wide awake and pain and all that. And so, you know, we settled her back down and everything. And then she stayed in the hospital for several weeks. So I'd stop in to see her, and every time I went in the room, she didn't remember me, but she would tell me the story about how we almost killed her in the hospital. So anyway, the moral of the story is, yeah, pain medicine can make you stop breathing. What had happened to her is that we had given her the same amount of pain medicine that we usually give her, but she had complained of some nausea later, and the nurse had gone in the room and given her some nausea medicine, and the two potentiate each other, so it really knocked out her drive to breathe.
After surgery, I had to be Narcan because the paper it was so scary.
Well, that's what happened to her, and I don't know, you know, I know the nurse knew that we had done the dressing change, but I guess, I don't know, didn't think about it, or, so she was really lucky that the day was ending up and the students were going down the hall telling all their patients goodbye, because she would have died. She was at the very end of the hall, and like I say, her rate was only 2 when we gave her the Narcan. If I wasn't waking her up, as long as I'd stay there and wake her up, she'd breathe. So, anyway, pain medicine, following surgery, any kind of procedure, you always want to be real careful that your person's still breathing. Okay, so what we want to be able to do is recognize a person when their O2 levels are just starting to decrease. We don't want to wait till we get all the way down here, right? We want to recognize it up here. So we're going to ask you on your test, and you're going to be asked in every single class that you are in here at the College of Nursing, like what are the early signs of respiratory failure? And those are going to be things like confusion, disorientation, lethargy, changes in mental status. Maybe the person's really agitated, or, you know, they're not chill anymore. They're real snappy and fussy and that kind of thing. So that is the first thing that's going to happen. That's going to happen before your respiratory rate goes up. It's going to happen before you turn blue. It's going to happen before your respiratory rate just peters out and slows down. Okay, so y'all, please always remember that. Changes in your mental status are where we want you to pick up on it. Yes, ma'am?
It says decreased LOC, what is that?
Level of consciousness. So again, any kind of neurological, they might say they're super sleepy, they may be confused, they might, not know their name anymore, or the date, or who the president is, or those kinds of questions that you ask. So LOC is level of consciousness. LOC also is an abbreviation for laxative of choice, so you'll probably learn it like that in pharmacology, but we're talking about level of consciousness. So then, a person's going to start breathing faster, and you're going to start to see their O2 sats going up. And then after that's where you start seeing those things like, movement of those, accessory muscles, your intercostals, nasal flaring. They might start turning blue. So by the time we get here, this is an emergency, right? Up here, it'd be really easy just to put a little bit of oxygen on the patient and they never get down to this part. Do y'all know what a dysrhythmia is? It's an abnormal beating of your heart. Okay. Y'all know what decreased capillary refill is? What's normal capillary refill? Less than 3 seconds. So what happens if a person has respiratory failure? How do we diagnose it? Well, you're going to be able to see it. They're not going to be breathing. They're going to be turning blue and that kind of stuff. We can do arterial blood gases. That's what ABGs are. Chest x-rays are not going to show you a whole lot. Chest x-rays, typically what shows up on your films in a chest x-ray is about a day and a half behind what you see clinically, right? So you don't really want to wait for 2 days to get a chest x-ray to figure out that they're having problems. And you can look at blood counts as well. And so what do we do for these folks? Well, we gotta ensure their airway. So we're gonna do whatever it takes to get them oxygen. It might mean just putting a nasal cannula on them. It might mean putting a mask. It might mean ventilating them. So we're going to do whatever it is we need to do to get them a normal PaO2 and get their CO2 down. Once a person's put on a ventilator, we can control how fast they breathe. So we can control what their CO2 levels are, and then we can, give them more or less oxygen to control that oxygen level as well. And then beyond that, we're going to do supportive care. And what supportive care means is we're just going to do whatever we need to do to keep the person alive. Like with DIC, we're going to do whatever we need to do to keep the person alive so that they their respiratory problem can get corrected. So if they have an infection, we'll give them antibiotics. If they've had some kind of trauma to their chest and made a hole in their lung, we're going to try and fix that. So we're going to fix whatever we can fix, but we're just going to try and keep them alive to allow that to resolve. Disorders. What causes them? So that means like who's at high risk and what causes the problem. What, maybe in 1 or 2 sentences, what happens in this disease process? I'll give you an example when we do pulmonary hypertension, but just a short little statement. This is the pathological process that happens. And then the signs and symptoms. And why does each of those signs and symptoms occur? So, we have the concept map set up like that. We have it set up like that on the study guide. If you want to make yourself a table that has, disease, cause, pathology, signs and symptoms, do that. If you're doing note cards, that's what you want to put on there. And just be sure that you know what the fancy words mean, right? So let's look at pulmonary hypertension like that, like that. So what you see there about etiology, that is the cause. What you need to know as the cause. So something, and for the most part, pulmonary hypertension, it's either secondary to like a heart problem, or it's an idiopathic issue. And so idiopathic means what? We don't really know. It just happens. So your etiology your cause, if you're going to set it up like that, what causes it is largely unknown, or it's secondary to things like heart failure or liver failure. Something that's increasing the pressure in your lungs, increased resistance to blood flow. So what happens, and I guess this is a good example of why you should be taking notes about the pathological process rather than relying on what's up there on the slide. But so if your lungs are stiff, the blood vessels are stiff, your heart has to work really hard to get blood there into the right side of your heart. So the right side of the heart is going to start to fail, right? Because your heart can only compensate so much, and then it's just going to quit working. So you have this high blood pressure. I guess the pathology is the blood pressure is high in the lungs. It makes the right side of the heart have to work really hard, and so the right side of the heart gets bigger and it fails. And so if you can understand it at that level, then you know it. okay? So that's what you would put either on the concept map or the study guide or your note cards or whatever. That's the pathological process. And so then the signs and symptoms, well, if you think about it, what do you think the signs and symptoms are gonna be related to? It's gonna be like your brain and your heart and the rest of your heart and the rest of your body not getting oxygen. Because if blood can't make it any farther than the out of the right side of your heart's getting backed up in the lungs, you're gonna have all kinds of problems with not getting oxygen to other tissues. Does that make sense? So you're gonna have things like real bad shortness of breath. That's gotta be up there somewhere. See, it says exercise intolerance is often the first sign, right? You're trying to walk up a hill or whatever, you can't make it. You're gonna get dizzy and faint a lot. You might cough up blood, that's what hemoptysis is. Pretty much any sign or symptom of anemia that we've already learned you could throw up there, because there's not enough oxygen getting to these tissues. A lot of people that have heart surgery or have stents put in will say that it's like they didn't even realize the things in their body that were tired, that didn't feel good until they got reperfused again. It's the same concept. The big thing that we worry about again, y'all, is this right-sided heart failure, and cor pulmonale is another name for right-sided heart failure. And y'all remember what the big sign of pulmonary edema is? Crackles. Shortness of breath, yeah, but crackles. Remember, from fluid volume overload and the edema that happens, you get the area around your alveoli fill up with fluid, and so you get crackles. So you're gonna get right-sided heart failure. So how do you go about diagnosing it? Well, there's gonna be the clinical presentation. Then they're gonna probably do some imaging to see is the right side of your heart bigger. There's a pulmonary catheter that can be put in, and they can measure the pressures in your heart. If patients have, and it's probably back on this first slide, if patients have primary pulmonary hypertension, these folks usually die within a few years. If it's secondary, and usually it's going to be secondary to heart failure maybe, then those folks live a lot longer because you can treat the underlying cause. So treating the underlying cause is pretty much what we do. They may take some vasodilating drugs. Some of the drugs that are used for erectile dysfunction are used to treat pulmonary hypertension as well, because they're such potent vasodilators. So you may see, an 82-year-old woman with pulmonary hypertension getting Cialis or Viagra. That's why they get it, because it helps perfuse. It helps dilate those arteries in the veins and arteries in the heart. Once it's advanced, it's going to be lethal eventually. But if it's secondary, you might get to live 20 years with it. If it just occurs for an idiopathic process, a lot of folks only live 5 or less years. So y'all know what syncope is?
You pass out.
You pass out. So when I was in nursing school, this is telling on myself. So we had been filling out this database, and y'all are going to fill out a database, and syncope was on there, and I had all been semester long marking my patient didn't have it, and I didn't even know what it was, but I got to the final exam, it was like there was a definition of syncope, and it's like it didn't occur to me until that point. I'd be saying that I must have been lying the whole time because I didn't even know what syncope was, but syncope means fainting. A pulmonary emboli, so you all probably are familiar with what a pulmonary emboli is. It happens most commonly in folks who have trauma of a long bone, particularly the legs, or people who are immobile and have any kind of pressure around their legs. So it's super, super common in these deep vein thromboses are super common in people that are in the hospital. So if you remember in skills, and this might have just been a week or so ago when y'all did the moving around the patients, crutches and all that, those SCDs, those little white things that look like big blood pressure cuffs on your legs. Pretty much every single patient that's in the hospital is either going to get those, or they're going to get a daily injection of a heparin to prevent that from happening. Because these pulmonary emboli, they're never events, they should never happen, and they used to happen all the time to people in the hospital. So lying still, letting that blood stagnate, is a huge cause. Fewer pulmonary emboli are caused by fat that gets out of the bone marrow and into your blood vessels. You can have an amniotic fluid embolism. Sometimes it happens that during childbirth, amniotic fluid will make its way into the vasculature of the mother, and those have very poor outcomes. An air emboli, whenever y'all do your medication checkoff, y'all can be so busy thumping those little air bubbles out of the syringe because you're worried about giving your patient an air emboli. In reality, is that tiny little, teeny tiny bubble going to do it? No, but a good 5 or 10 mLs of air would do that for a patient. And then you can also have foreign material that can cause a pulmonary emboli. When you do your IV checkoff and your central line checkoff, I was going to say, anytime you take something out of a person's vascular space, you always look to make sure that the whole thing is there. Part of the catheter didn't break off or anything like that. And then you can also, if you're septic, and you'll learn about that in the sepsis lecture, but you can have antibody clumps that can cause an emboli. So anything that causes your blood to not move, the big thing there really is immobility. Anything that makes you hypercoagulable. What kinds of things do you know that make people hypercoagulable? The three that I think of are severe dehydration, right, because there's way more platelets and blood cells there than there is liquid. Cancer makes a person hypercoagulable. So it's common that folks who have cancer develop blood clots. And birth control pills. So those three things tend to make people more hypercoagulable. Risk factors, there you go. Immobility, trauma, cancer, heart failure, estrogen use, that's the major player in a birth control pill. The reason that trauma does is probably because you've bled a lot, you've had a lot of replacement, and you're immobile afterwards. Okay, so what happens? This blood clot, or the piece of the IV tubing or whatever, breaks off and it travels through your vasculature. It's a blood, so the blood clot's the thrombus, so it's traveling through the blood vessel. And then when it gets out up into your lungs, it's going to work its way out as far as it can go until it plugs up a space in the lung, in the blood vessels of the lungs. Right, so the bigger the blood clot, the more blood flow that gets closed. Does that make sense? If it's something tiny like a piece of lead, like the lead of a pencil, you might not have any feeling at all. If it's a clot that's as fat as my finger, it's going to plug a big portion. So wherever that blood clot occurs, from there forward, that tissue is going to die because it's got any blood flow coming to it. So that's what a pulmonary emboli is. A clot or a foreign body of some sort, or amniotic fluid or whatever, makes its way into the vasculature of your lungs, and it prevents blood flow beyond that point, and then that tissue is going to have a big inflammatory response and would likely die. It's going to increase your pulmonary vascular pressure. Infarction means death, like myocardial infarction. It means that you've lost the blood flow there, and that tissue is going to die. If your lungs fail, if it's on the left side, if your lungs fail, you're going to end up with heart failure, rapidly progressive heart failure, as in minutes heart failure, hours heart failure. So people very often die immediately from a pulmonary emboli. How many of y'all watched the Heartland series? Any of y'all watch that? No. I'm trying to think of who. Did any of y'all watch Dexter? So that's how Dexter's sister died. She had a pulmonary emboli. Oh, I hope that's not a spoiler alert. Are y'all watching it now? Oh, shoot. Yeah, I didn't think about that. Yeah, that's like a 10-year-old series. I just figured everybody had seen it. But, and then if you watched Heartland, the vet guy, he had a pulmonary emboli. So if you have a pulmonary embolism and it's big like that, patients will die before your eyes very quickly. If you have a smaller pulmonary emboli, you may have severe signs and symptoms of respiratory failure that happen quickly. One of the telltale signs of a pulmonary emboli is this thing right here, the sense of impending doom. So patients who have pulmonary emboli, I love Dexter, by the way, too. I love it. It's like the only time you ever root for the bad guy. I'm sorry, didn't occur to me that y'all might not have seen the whole series. Okay, anyway, so patients will tell you, please don't leave, there's something wrong, will you stay with me, don't leave, I'm scared, I'm gonna die, and they look just as normal as you and I look, and then they have a pulmonary embolism an hour later or 2 hours later and die. So anytime somebody tells you that they're a patient, I'm scared, please stay with me, you need to. You need to do a good assessment, you need to get somebody else to come in and assess, and you need to be ready for something bad to happen. Happens. It's a very true thing, that sense of impending doom. Aside from that, they're going to have a sudden onset of chest pain and real bad dyspnea or shortness of breath. They're going to be panicked. They'll start having changes in their heart rate and their respiratory rate as well. So that sense of impending doom is the big one. In addition to having signs of other respiratory signs and symptoms, they may be coughing up some blood too. So what will happen is, if the patient lives long enough, they'll take them down and do a VQ scan on them, and they'll get that high or low VQ ratio, high, and then they'll start them on anticoagulants. If they survive long enough, they may take them to the operating room and take the clot out. Like some of those big clots, they'll go in and take out. Now that putting them on an anticoagulant is not really going to break down that blood clot, but it'll help them keep them from forming more blood clots. They're going to get oxygen, they're going to get blood pressure medicine, they're going to get whatever we can do to keep them alive until we can get that clot resolved there. You see this, I think I have a picture of this vena cava. An embolectomy is taking them to surgery and taking it out. Prevention's the big thing. So I mentioned before, pretty much everybody is going to have on SCDs or be getting a daily shot of Lovenox. And again, y'all, ambulating your patients is probably the best thing you can do to prevent many, many things, and pulmonary emboli is one of those. This is a picture of those filters where it said vena cava filter on the slide there. These are wire filters that go and they hook in your superior vena cava so that if there's a clot, it's not going to make it up to your lungs or to your brain. And so that filter will trap the clot, and while you're so hopefully you'll still be anticoagulated so it doesn't get any bigger, and eventually your body will break that clot down. Even if you're not getting any anticoagulants, I mean, we all day long, we're making little clots and breaking them down, so hopefully that will get broken down. Once one of these vena cava filters gets put in, they stay in forever. Unless it's caused a problem for the person, they'll go back in and take them out. Okay, lung cancer. Lung cancer is still a major or leading cause of death. It's most of it is associated with cigarette smoking. Not everyone who has cancer are smokers. Yeah, we had a person from, I think, Fairhope die recently. She was like 28 years old, not a smoker, who died with with lung cancer. So, but if you do smoke, it's more likely that you will develop cancer. Y'all, if you smoke, you just need to go ahead and consign yourself to the idea that you're going to get lung cancer. It's just when are you going to get it? You know? Are you going to get to live to be 90 with it, or are you going to die at 60, or just don't smoke. So there's different types. I'm not so concerned that you know what type it is. It's super important that you know, though, that what we know about all cancers. Anything that causes chronic irritation and a chronic need for reproduction of those cells is going to lead to the development of those cancers. I don't really think I care too much about you learning about the different kinds of cells. You can read through that if you want, but I'm more concerned about you grossly knowing what lung cancer does and how you get it. And so you're gonna get it from abuse of the tissues of the lung. Mostly it's gonna be, cigarette smoke is the main cause, or secondhand smoke. It's gonna probably metastasize. So by that, we mean it's gonna grow and it's gonna spread. So I do need you to know these signs and symptoms though, y'all. So a change in voice or hoarseness is a big sign. Typically patients will have, will say that they've had a cold that just won't go away. My mother-in-law died with lung cancer a few years back now, and it's exactly what had happened to her. We were at someone's birthday party the end of August, and she was telling, she was fine. She had lost weight, but she was a thin person anyway. And she said, I just got this little scratchiness in my throat, and I haven't been able to get rid of it. I went to the doctor, and they said I have bronchitis, and I've been on antibiotics, and so that was like the end of August, and she died in November. So I was actually lecturing one day down here in Patho, and her boyfriend of 29 years called me to say that he was taking her to see a pulmonologist, that she's had this cold she hadn't been able to get rid of, and they did an x-ray, now they're sending her to see pulmonology. So I thought I'd had fix it, she's got cancer, right? And so we went over there, and sure enough, that's what she had. And so it was probably September that she got that diagnosis, and she died in November. And that's the typical presentation. It's usually very far advanced before people start having signs and symptoms, and before they go and get help, and so it doesn't usually have a good outcome. So she had increased sputum, she had a cough. She never said she was spitting up blood. She didn't have any chest pain, but those are the big things: the losing weight and changing in your voice, and a cold that just won't go away, a scratchiness in your throat that won't go away. She had lost weight, which we know patients that have cancer do. I don't know if she was anemic or not. She did not have that facial or upper extremity edema. Why do you think somebody that has lung cancer might have facial or upper extremity swelling? If you're growing a big old tumor right here, and you've got all these major blood vessels in your heart right there, it's gonna block that flow, so the blood's not gonna be able to get down very much, so it's gonna make you swell up top. So this is what they did. They had done the x-ray, they sent her over to see the pulmonologist, who scheduled her for a biopsy, a bronchoscopy with a biopsy. So you could probably really tell from looking at the chest x-rays and the CT scan. That biopsy is taken so that you can determine what type of cancer it is. Is it adenocarcinoma? Is it squamous cell? And that's really for the oncologist to figure out what they're going to do as far as chemotherapy or treatments go for them. So they may see on the chest x-ray, you can see the mass. You can see that maybe the lungs are pushed farther apart because there's a tumor growing in there. They may have developed effusions, which is what this is right here. It's a collection of fluid there. And then the treatment's going to be maybe radiation. Most patients who have lung cancer get radiation. Some will have surgery, and some will have chemo, depending on what's going on with it. It's just a picture of a bronchoscopy. They sedate you pretty heavily, and they put a tube down, a scope. They can look and physically see the cancer, and they can put tools through the end of that scope and clip out tissue for the biopsies. So we're going to talk a little bit about obstructive diseases of the lungs. And so by that, it means it obstructs the airway. These diseases cause some kind of obstruction in the airway. Ooh, I don't remember hitting that twice, but I did, huh? Okay, so asthma is the first one we're going to talk about. Some books categorize asthma as an obstructive disorder, some don't. Asthma can be genetic. It occurs more commonly as in young adults or kids in males as it does females. We don't really know why. It can be hardly noticeable, or it can be life-threatening. It is triggered by some kind of allergen. So we're gonna look at what different allergens are. They're different for different people, but you have an exposure to an allergen that sets off an inflammatory response. So these are some just common known triggers. If they are intrinsic, it means that they don't really think it's a pure allergy, but the response is the same. And then the ones that are extrinsic are. I'm not gonna ask you, is this intrinsic or extrinsic? So I wouldn't try to memorize a list of which are which, but I would try to understand or get a good feel for the common things that can cause, set off asthmatic events for a patient. So this is what happens. There's some kind of allergen, some kind of antigen that gets into the person's airway, and that inflammatory response happens in a big way. So there's that release of IgE and eosinophils, and what those things release? Histamine, and what does histamine do? It causes the opening up, the vasodilation, and the increased pulmonary increased capillary permeability. So fluid's gonna start leaking in, right? So you're gonna get more fluid in there. It also causes bronchial constriction, so the airways are gonna constrict down, and they're gonna start filling up with fluid. So you can see right away that that's not a good thing to happen, right? That vasodilation is gonna make your blood pressure lower, right? And so now you've got your blood pressure may be getting lower, you're dumping all your fluid out into the lungs where that antigen, the trigger, is causing it to happen. And so your airways are gonna fill up with air. So are gonna fill up with fluid, so that fluid's gonna make for more mucus. Over time, so patients that have asthma, always have asthma, right? But there are medicines that can be taken, there can be this avoiding of their allergens, and all that helps keep them controlled. And then they off and on have asthmatic attacks or events where they have this inflammatory process and this bronchial constriction going on. So the more often that these events happen, the more inflammation, the more scarring. So over time, if a person has uncontrolled asthma and they have lots of these asthmatic events, these exacerbations, it's gonna lead to scarring of their lungs, and in the long run cause chronic obstructive pulmonary disease. It's one of the diseases that can cause that. That's what COPD stands for, chronic obstructive pulmonary disease. So this is what a normal airway looks like, cross section. You can see that's, got a pretty smooth muscle wall here with the bronchial tubes, and there's not a lot of fluid in there. So you can see here where the airways have clamped down, and you can see how they filled up with fluid, which makes for more mucus. So you can see how much loss of space they have to exchange gas. So the signs and symptoms, the big one is wheezing. So they're gonna have, they're gonna have increased heart rates, they're gonna have shortness of breath, their O2 sats are gonna fall. That's gonna happen to everybody that has a pulmonary disease, pretty much. But the wheezing is the telltale sign. When those airways clamp down, it's like when you try to whistle, and I can't whistle very well, but if I just, nothing's gonna come out. But if I curl my tongue up and blow air now through that little bitty opening there, that's what makes it. So that's what a wheeze is. It's kind of like a whistling inside of your airway. I've always been jealous of people who can whistle well. Can't do it. So they may be using their accessory muscles. They may be turning blue. They can have any of those signs and symptoms of respiratory failure that we already talked about. But the big one that's going to help you identify that it's asthma is the wheezing. So we're going to ask you, like I will ask you on the test, I'll give you, there's going to be bunches of diseases on there. And, they're all going to have dyspnea, shortness of breath, tachycardia. And so you're going to need to know why those happen, which we've already talked about why they happen. And then be able to know the difference, like, what is different about asthma versus emphysema versus bronchitis versus pneumonia. Did you raise your hand or were you just stretching? Yeah, I was stretching, okay. So how does it get diagnosed? Well, they can do pulmonary function tests. A lot of it will be based on what the person says when they come to get help. You know, they'll describe what it, when it happens, how it happens, and so then they'll probably get some chest x-rays, do some pulmonary function studies, maybe look for these Charcot-Maden crystals, and that's how it's going to get diagnosed. So, patients who have asthma, and that pretty much all these respiratory diseases, they get drugs that help prevent bronchial constriction, so bronchodilators. They may be on steroids as well. And then certainly antibiotics if there's a flare-up. And oxygen therapy when there's a flare-up. Bronchitis is another obstructive disorder. Bronchitis a lot of times is a viral or bacterial infection. So it's very common in kids to get bronchitis. And bronchitis every now and again is not any big albatross of, bad lung function as an adult, but repetitive incidences of bronchitis does lead to COPD. So in bronchitis, what happens is that you're going to have swelling in your airway, but you don't get that constriction that you get with asthma. So it is an inflammatory condition. So you'll get, the bronchial tubes will thicken up, so your airway's going to go a little bit smaller, but not clamped down small, and you're going to have more mucus in there. Patients may have, we'll wait till we get to the signs and symptoms. So they may have signs and symptoms of a cold. I was going to say they might have a fever. They're probably going to have a cough. Malaise just generally I don't feel good. So pretty much everybody in this room, you've had bronchitis at some time in your life. Think of it like a bad cold. The diagnosis is going to be based on the signs and symptoms, maybe a chest x-ray. Like my mother-in-law who had lung cancer, she came in with the classic signs of bronchitis, so kind of the first thing that happens when you go into, something like on the dock in the box, but like a little urgent care clinic or whatever, they're going to give you some antibiotics and some steroids, and hopefully it gets better. And then hopefully it's going to be self-limiting and it's going to go away. Or they get antibiotics and it's going to go away. Chronic bronchitis is, the difference is acute, there's some kind of infection, it's a short event and it goes away. Chronic bronchitis then is not the same, there's not really an identifiable trigger, but you have chronic inflammation in your airways. It's common that any of these asthma that we just talked about, bronchitis or emphysema that we're going to talk about next, that if you have one, chances are you're probably going to have another one. You might not start out with just one, but 10 years down the road, you're going to have a compilation of those different diseases. So again, these folks are going to have a inflamed airway and more mucus in there. So the telltale thing about these folks is that they're kind of dusky looking. They're typically swollen people, big puffy people because it's a chronic inflammatory condition, and they don't get air in well. So they're called blue bloaters. If your lung is permanently inflamed or inflamed for more than a day or so, and it's half filled up with fluid, so there's no gas exchange, you can see right away that they are not going to be exchanging oxygen very well. Over time, just like with asthma, if you have bronchitis, lots of bouts of bronchitis or lots of flare-ups, you're going to get more scarring, more poor lung function, and you're going to end up again with COPD, chronic obstructive pulmonary disease. So signs and symptoms are going to be lots of signs and symptoms of cold, cough, fever, that kind of thing. These folks are going to have, like I said, be kind of dusky, and because it's, and I mentioned this before, but because it's an inflammatory process, they're going to retain a lot of excess body fluids, and they're going to look like just swollen people. Faces, necks, chest, they're going to be puffy and swollen. Remember we said we want to find out that people are in respiratory distress before they get to that cyanosis and seizures and all that kind of thing. So they're going to have poor respiratory function, lots of sputum. Over time, they're going to develop right-sided heart failure. So it's gonna be diagnosed based on their clinical presentation and their films and pulmonary function test. So if a person has bronchitis that lasts for more than 3 months, 2 years back to back, then they're said to have chronic. So again, those little individual bouts here and there where you get bronchitis for a few weeks, there's not really to be concerned with too much, other than taking care of it at that time. So what do we wanna do? We wanna try to prevent the progression of this disease as best we can. To do that, the person's gonna need to get rid of any kind of, triggers they have. Cigarette smokers are bad one, so they're gonna need to quit smoking mostly, get a little more mobility to them. And so then we wanna preserve their function as long as we can and help them, get back to baseline as quickly as we can. Yes, sir?
Is it ever possible to reverse COPD at all?
So, you know, like my dad has emphysema. He smoked as a young man, probably from the time he was from a boy to the young man as a kid. And he probably stopped smoking around about the time he was 4, he's 83 now. And so he works really, really hard. He has an incentive barometer, he's got one of those acapella devices, and he's constantly, and so his pulmonary function has gotten a little bit better, but it's never gonna be. Because I mean, once that scarring and stuff is done, you can't undo that, but you can certainly strengthen the non-damaged tissue to help those functions better. And he's done really well with it. Where are we? Okay. So these folks are typically gonna be overweight, they're gonna, be blown up looking, that's what they're called, blue bloaters. That's kind of the same thing we've already said, but there's just a picture of a person that you would think that, just from looking at him, that he would, you know, about that big old belly and his big face. Another picture of a person that's very bloated. So the treatment, the good thing about all these obstructive disorders, and even some of the restrictive ones we're gonna talk about, they're pretty much treated the same way. They're gonna get bronchodilators, they'll get antibiotics when they need, if they have an infection. These folks that have these COPD diseases, again, they can live normally, taking their bronchodilators, maybe they are on a low dose of an antibiotic and that kind of thing, and then there's some kind of exacerbation, like they get a cold, they get a pneumonia, there's some kind of virus that they get that will cause a flare-up of their condition, so that then they end up having to come to the hospital. So patients that have COPD diseases, they may live 40 years with it or 50 years once they're diagnosed with it, as long as they can manage it well. Like my dad that has emphysema, so my mom was a nurse, and she had another disease that I'll tell you about, but he learned from her, like my mom, whenever she could get the first sign of a cold, I've got a son-in-law that's a doctor and my daughter's a nurse practitioner. So she would ask, she'd say, will you get them to call me in some antibiotics? So the first time she'd get any, snot, for lack of a better word, she'd start taking an antibiotic. And so she lived probably 10 years longer than she should have with her condition, because she was able to manage or prevent all those exacerbations. So my dad does that now with his emphysema. As soon as he gets a cold, he'll call me and ask me to, get my daughter to give him some antibiotics. If you're smoking, you gotta stop smoking. You need to take your medicine. You need to try to keep yourself from getting sick. All the things that you learned in COVID about being around large crowds and washing your hands and all that kind of thing is super important for people that have these chronic pulmonary conditions. And they will be, again, on steroids. If they're really puffy and swollen, they may get some diuretics. Emphysema is called type A COPD, bronchitis is type B COPD. Here you go, this is where my daddy fell. 99% of the people that have emphysema smoke. 99% of the people who smoke are gonna get emphysema, and they're gonna get lung cancer too, if they don't quit smoking. So there are other things that can cause emphysema. Maybe you work in an industry where there's particles of something in the air all the time, that can cause it, but by and large it's smoking. Now you can develop emphysema without smoking because you have this alpha antitrypsin A. It should be up here somewhere. Right here. You can have a true deficiency of alpha antitrypsin. That's 1% of the people who have emphysema. That's a very, very small portion. But what happens is if you smoke, you block the activity of this. And what this antitrypsin does is it prevents enzymes from breaking down the walls of your alveoli. It's a protective thing. So when you smoke, it inactivates that. Therefore, these enzymes break down the inside the walls of your alveoli. It causes an inflammatory process. The end result is going to be death of a lot of the alveolar tissue. And after it dies, you get this enlargement of your distal air sacs. So the example I usually use is, you know those tiny little balloons that you can make water balloons out of? So the first time you blow, if you try to blow that up, you know how hard it is to blow that up? And it'll fill up, and if you let it go, you just let it go, it's probably gonna fly up the ceiling, it's gonna have so much elastic recoil, it's gonna take all the air out of that balloon, it's gonna shoot off. That's the way your alveoli should work. They should collapse down like that and squeeze all the CO2 out of your airway. Well, if you have emphysema, now picture blowing that balloon up and just keeping it, twist it off and keep it blown up for 4 or 5 hours, then let it go. Is it gonna shoot up to the ceiling like it did? It's all stretched out now, right? It's saggy, baggy. It's almost become like a plastic bag instead of a balloon. And so now when the person exhales that has emphysema, they don't get that snapping that forces that CO2 back out. So they end up with these alveoli that are dilated and they're full of CO2, carbon dioxide. So their problem is not that let me go further, get to the next thing. Their problem is not that they can't get oxygen in. They can get air in, it's just they can't get rid of it. So they end up with this right here, air trapping in the distal alveoli. So this is a cross-section of what normal alveoli should look like. And see, again, every one of these little walls right here should be able to contract and help squeeze CO2 out. Well, you can see up here where they've lost all those little walls. So now it's just this dilated mess that's not going to function very well. So classic for a person that has emphysema is that their faces look pink and ruddy. And it's because they have to work so hard to breathe that it's hyperactivity. Plus, carbon dioxide causes vasodilation. So if I've got high levels of carbon dioxide, I'm going to be a little more vasodilated, which is going to make me look a little more pink. They're called pink puffers because a person that has emphysema probably breathes about 40 times a minute. It's probably their resting respiratory rate. So they look like they're puffing. They breathe like that. And they're kind of pink because they're retaining all that CO2 and working so hard to breathe. They typically are thin people, and they have a barrel chest. Do y'all know what a barrel chest is? Okay. So what's the normal AP diameter? 2 to 1. You don't want it to be 1 to 1. You should be twice as wide this way in your chest as you are this way, front to back. They typically will lean forward, maybe prop themselves up to breathe. They're trying to stretch out the space that those saggy airways have to live in. They will get digital clubbing. All of these folks will get clubbing. The treatment's going to be very similar. Avoid things that can cause infections. They're going to be probably on a steroid, and they're probably going to be on an inhaler. Bronchiectasis is the last of the, no, it might not be the last. It's one of the obstructive lung disorders. And what happens here is that you get permanent dilation of the airways. This occurs most commonly in folks that have cystic fibrosis. That's where it happens the most. So these, when you get out near the ends of your airways, these airways get distended and they retain mucus. So basically, that's what you get. You get inflammation, dilation, and purulent secretions. And if you could say that, retaining thick, sticky sputum. That really is enough for you to know about what bronchiectasis is. These dilated airways, they retain sputum. Emphysema, loss of the alveolar walls, and saggy airways. Asthma, it's an inflammatory condition that causes bronchial constriction and retaining of mucus. That really is the level at which you need to know that. And that's much easier to understand it that way than it is to try to memorize every word that's on these PowerPoints. So you can imagine they're gonna have all kinds of signs and symptoms of respiratory issues. They're gonna have clubbing, they may have shortness of breath. If they have an infection, if those secretions are infected at the time, they'll have fevers. They'll have a cough, and they're gonna have this really sticky, this is the telltale thing for this one, copious, foul-smelling green. Should have sticky up there. It's real thick and tenacious, real thick sputum that's hard to cough out. Y'all know what hemoptysis is. I'm not really sure why they have night sweats other than, I would think they have sweats all the time. That's just a picture of what clubbing is. Y'all know what clubbing is? I think I've already told you in health assessment. Again, look, the treatments are gonna look very similar. Chest physiotherapy. Chest physiotherapy is like you have percussion, you might do it with your hand, or they have percussion instruments that pound on the chest, and it helps break up those secretions so that you can then cough them up or suck them out. Cystic fibrosis is the last one in this little portion of this lecture. So it's a recessive disorder. So it's going to take, two bad genes for a person to develop cystic fibrosis. And there's your categories of folks who get it and how long they typically live. Their survival rate's getting much better now. Like when I was in nursing school and getting out, like people only lived to be about 16 or 17 years old if they had cystic fibrosis. So now the lifespan's gotten much longer with the onset of some new medicines. So what happens in cystic fibrosis is that there's a problem with the patient's chloride channels, so that patients lose sodium. Because sodium and chloride typically go together. And so if the patient loses chloride, they lose sodium. If they lose sodium, what else do they lose? Water. So these folks have a very hard time maintaining bodily fluids. When we think about cystic fibrosis, we typically think about all the respiratory issues that it causes, but it's going to cause problems everywhere, right? Every organ system that has much of anything to do with fluid. So people that have cystic fibrosis, well, first of all, they're going to get diagnosed probably as a baby. But the first signs and symptoms that are going to show up really are going to be GI related. And then the respiratory signs and symptoms are going to show up later. The other, like sterility, clear, you're not going to figure that out until you're much older. So what happens is that because there's not much fluid, the enzymes that are in your pancreas can't make it into the person's stomach or gut to help break down foods because of the lack of fluid. It's not going to be able to flow out. And that's going to cause this, they're going to make them very thin, small people. Sweat glands, they're going to sweat a lot. They'll taste very salty. Like if you lick a person that had cystic fibrosis, they're always going to taste very, very salty, like they've been sweating a lot. So because they don't have the enzymes to break down those nutrients, they're going to be very thin folks. They're going to have troubles breaking down fats, proteins, and sugars. Just across the board, they're going to be nutritionally deficient. That's going to be the first thing that shows up. And then the one that's more concerning though is what happens in their airways. That CHO is for carbohydrates. That distracted me when I looked back there. So in the airway, because their respiratory secretions there's not going to be many respiratory secretions. The stuff that does get into their lung, it's going to be real thick and tenacious. It's going to be hard to get it out. And so they're going to develop frequently have pulmonary infections. And it's those pulmonary complications that are going to end up causing this patient to die at a younger age. So they'll have airway obstruction, they'll retain their secretions. Atelectasis is the collapsing of alveoli. So they're going to just have very, very bad lungs. So what are they gonna look like? Well, think about what a person who doesn't get oxygenated very well looks like, and a person who basically can't absorb any nutrients from their diet. They look like they're gonna be very frail, puny. They're gonna have what's called failure to thrive. They're just gonna not gain weight. They're not gonna progress. Now, neurologically, they'll do okay, but physically, they're not gonna get big. They're not gonna develop. They'll have lots of infections. It's typically those respiratory infections that take the patient to the hospital, and it's usually a respiratory infection that will cause the patient to die. They will eventually end up with right-sided heart failure, right? Because their lungs are just getting damaged. The same is true for asthma, emphysema, bronchiectasis, bronchitis. All of those chronic lung conditions are going to lead to heart failure. And then it's going to be the heart failure that lets these folks die. They may have sternal retractions because of the because of trying to get those thick, tenacious secretions out. The rest of those pretty much look the same. Hyperresonance means they've trapped. Y'all know what resonance, the sound, how you get resonance over the lungs from having air, extra air. So if they're retaining air, trapping air, same thing with emphysema, they would have hyperresonance. So something else that's equally important to understand this is about their GI tract. Folks that have cystic fibrosis need a huge amount of calories. They will take enzymes when they eat. So we can replace those enzymes so that they can break down their fats and proteins and carbs. So they have to take those with their meals, and then they need to eat a lot of meals, like maybe 6 a day. It needs to be high calorie, high protein, because we want to do everything we can do to help this person maintain their weight. Yeah, they kind of have two strikes against them on their weight. They don't have those enzymes to help them break things down, and then their little body's going to be working so hard to try and clear their respiratory system that they're going to not hold on to weight very well at all. They'll get all kinds of supplements with vitamins and nutrition concoctions. And we've already said this before, getting an infection is going to be the leading cause of death. Children that have cystic fibrosis will get chest physiotherapy 2 or 3 times a day. So the families are taught how to do it. I guess depending on your insurance or whatever kind of Medicaid you have available, or there are resources where folks can get chest physiotherapy machines, is what I'm trying to get at home, where you may have to hand, and they'll have to have their enzymes replaced. They may have to take salt replacements as well. Disorders that we talked about were obstructive disorders, meaning that they obstructed the airway somehow, either swelling or mucus or whatever, they blocked the airways. Now we're going to talk about restrictive disorders, and what restrictive disorders do is they restrict the lungs' ability to do this. Basically, the lungs get scarred down or fibrotic, and they can't expand, relax. So the first one we're going to talk about is, it's a very large group, and they're called interstitial lung diseases, and there's a whole bunch of them. This is what my mom had. A lot of it's very idiopathic. Sometimes it'll follow a person having a different disorder, but 9 times out of 10, we don't know why it happens. It just does, and it's a very unfortunate situation. So the patients will get pneumonias, and their airways become so restricted that they can't oxygenate anymore. We don't really understand why it happens or what's going on, but again, there's this chronic inflammation that goes on in the lungs. And then remember, we said the end outcome of an inflammatory process is scarring. And interstitial, I guess I should have started with that. Interstitial is the tissue that's in your airway that's not your airway, and it's not your blood vessel space. Right? Just like we know what interstitial spaces are. These are the tissues of the lung themselves where the perfusion happens. It's not the alveoli where the gas is changing place. It's all that tissue around. It's the solid part of your lung. And so that tissue has some kind of chronic inflammatory issue going on, and essentially it just scars down. And you all have scars. They're hard. They don't expand and contract. And so eventually or essentially what happens is the person, they can't inhale and exhale anymore. It's like there's no closing down or tightening up of the airways that blow air out, because the tissue that's surrounding them becomes like concrete. It just keeps everything fixed in place. It can be diagnosed, it can be reversed if it's an acute, short-term event, but most oftentimes it is not reversible. So you're gonna end up with, again, this massive scarring throughout their lungs, fibrosis throughout their lungs, which is gonna make their lungs look pretty much white, or that honeycomb appearance that you see there. Over here. So a normal lung looks like. Air comes up black on an x-ray. So you can see all this tissue now that is scarring down and keeping those, making the lungs non-compliant where they can't contract and expand, contract and expand. So the most common sign is a progressive, non-productive cough. So the patient coughs and the cough just keeps getting worse, but nothing comes up. They're gonna have other signs and symptoms of respiratory failure, with dyspnea, and they're gonna start having lower O2 saturations and that kind of thing. So my mom she probably weighed, when she was diagnosed with this, she's about my height, I was probably a little bit taller than she was, about 125 pounds, and the last time we weighed her before she died, she weighed 75 pounds. Sad. But it was so hard for her to breathe, right? Her respiratory rate was 40, and it was so hard for her to breathe that it's just like having cancer. She lost weight from that. It's hard to eat anything, but I would say this when we tell a patient with emphysema, but if you're breathing 40 times a minute, it's hard to eat. It's like going and running 2 miles, and as soon as you stop, eating a hamburger. After you stop running or you stop exercising, you slow your breathing down. If you're breathing that fast, when do you chew up your eating? When do you chew up what you've eaten? Yes, sir?
Could there be a lot of choking hazards with people with emphysema?
I don't think the choking hazard's any worse than as far as choking on a foreign object. Like my sweet little mama, she would have these coughing fits so again, it's non-productive. But she would cough. Then every time I saw her have one of these, I thought she was gonna die. It's like every time she'd have one of those little bits, and she lived with my dad, She lived with me the last 8 weeks of her life, but it got to where, like my dad, he would be real nervous, and he would I think he spent all his time out in the yard, so he didn't have to watch it, right? Because, after you've seen it a bunch, and she's gonna be okay, there's nothing you can do about it, it's very hard to watch. But they lose a lot of weight because of that, and eventually you're not moving any air. What else does it say up here? If there's any kind of triggers, get rid of that. Steroids are controversial. Lots of studies show that steroids don't really do much good for these disorders. You can do a lung transplant, but lung transplants are hard to come by, and they're very expensive. And if you get a lung transplant, you're only going to end up with about 40 or 50% of your lung function anyway, so they don't really do lung transplants much for this. So this is ARDS, Adult Respiratory Distress Syndrome. This is another kind of fun thing for me to talk about. It's something that happens, it's idiopathic. It's much like the same things that can cause DIC, big traumas, big infections, big surgeries, cancers, lots of things like that can cause it to happen. But it's very idiopathic. The hallmark sign is this phrase right here. And what that means is that no matter how much oxygen we give the patient, we just can't get their oxygen levels to come up. So refractory hypoxemia. It's just not, we can't get it to go up. I'm freezing. Are y'all freezing?
Yes.
Okay. So again, any major stressor to the body can cause it. So it's very common, I told y'all I worked in the burn center, it's very common that burn patients got ARDS. So to help you remember, there's a big assault somehow or other to the pulmonary system. you get respiratory distress, you have poor lung compliance. Lung compliance is that ability of your lungs to expand and contract. You know how we just talked about the problem that happens in patients that have interstitial lung disease, that their lungs get like concrete so they can't move? That's what happens with ARDS. That's what that compliance means, and they end up with severe respiratory failure. Whoa. So there's a widespread inflammatory response. So the patients are going to have lots of fluid in their lungs. In that inflammatory process, if you remember, we talked about the release of fibrin and fibrotic tissues. So those get released and it stiffens up the airways so that the airways can't move. The amount of surfactant is lost, and that also contributes to those alveoli not being able to open and close like they should. So the lungs just get stiff. They're called stiff lungs, non-compliant lungs. And so you can't, if you don't collapse and expand, you don't move any air, basically. You end up with shunting here. Remember we talked about the gas and the oxygen in the blood changing places or moving, but there's no exchange, and it's because of all that fluid in the interstitial space. There's no way for the gas exchange to occur. So what are they going to look like? They're going to have a shallow, rapid respiratory rate. They're going to have that falling off of their oxygen levels despite the amount of oxygen that we give them. They'll have lots of, like you'll be suctioning out a lot of fluid, lots of fluid loss in their lungs. That's the big thing, the crackles, wheezing, and it's diagnosed really kind of based on the signs and symptoms. So, well, there's that clinical presentation where we already know they've had this big trauma event or this big stressor that's going to predispose them to developing ARDS, followed by the hypoxemia, and we keep trying to jack up their oxygen levels, and we can't do it. There is, right here, PEEP. PEEP stands for positive, I don't have it written out there, positive end expiratory pressure. You don't have to know what it means. I mean, you don't have to know what the acronym stands for. But basically what it is when you exhale, when we all exhale, we have the equivalent of about 5 centimeters of water pressure still in our alveoli that keep them from collapsing down flat. Well, folks that have ARDS, they collapse flat. And so when a patient's on a ventilator, you can turn up that PEEP so that we give them higher end expiratory pressure to help keep those alveoli, those small airways, from collapsing. So that's what we do. We turn their PEEP up real high. They get high levels of oxygen, and their O2 sats still don't come up, and that's how they get diagnosed. But to treat them, we're going to keep doing the same. We're going to keep trying to change the pressure in their chest, keep trying to give them more oxygen, and then try and get rid of whatever that stressor is that caused the problem to begin with.
Can you explain again what the high pressure, the PEEP does?
It's the pressure that keeps the alveoli from collapsing completely flat.
Okay.
So if you think about when you're inhaling and exhaling, if this is an alveoli, they should fill up, and then they should collapse down to about here. But these, they just fall flat. So it keeps those alveoli open a little bit. So we're going to try and keep them alive until this goes away. Do you remember during the pandemic, and they show you the patients that are super sick and they're in the critical care unit and they're laying on their chest? They've got them laying face forward. That's what they're trying to do, is they're trying to increase the pressure on the chest to help keep the airways open. I think I have a picture of that coming up. So this is a chest x-ray on this person. It's similar to that one from the interstitial lung disease, but see, it's just completely whited out. Unfortunately, this isn't really going to show up until they're about 2 days into it. So you can't really rely on that chest x-ray to diagnose it. It's going to be diagnosed because of the clinical signs and symptoms. And then there's a person prone. So that helps increase the physiologic. Physiologic PEEP means the amount of PEEP that we have naturally to keep our airways open. But they do pronate these people. And you can see why right away somebody's got a tube, coming out of their mouth for their airway. They probably have an NG tube having them laying on it's not ideal, so we don't like to put people on their stomachs, but. Okay. Well, that was quick. So we have respiratory infections to talk about. The ones we're going to spend the most time talking about are going to be pneumonia and TB. We're going to talk about the common cold. So y'all all know the common cold is, right? You know what the signs and symptoms are. The common cold is caused by a virus. Usually, well, it is. If it's a cold, it's a virus. And there's lots and lots and lots of viruses that can cause upper respiratory infections. So that's why you can get multiple colds, right? But you really shouldn't get a cold from the same exact virus twice. You should get some immunity after the first one. But there's just so many of them out there that there's going to be colds around to last you a lifetime, but you can always get a few colds. Yeah, I mean, y'all know what a cold is, right? You get a runny nose, you might have a fever, you might have a headache, you might be coughing and sneezing. It should be self-limited, and you treat the signs and symptoms basically. You are contagious from before the signs and symptoms occur until about a week afterwards. I was looking, I think that's everything. We don't really need antibiotics. Again, a lot of times if you go to an urgent care or even to a primary care office, people when they go to seek health care, they want something when they leave, right? They don't want to be told, well, it's just going to have to go away, go home and let it run its course. So it's very common that the patients will be given an antibiotic and they're given a steroid as well. And the reason for that is the steroid's going to make you feel better right away. You know, 6, 10, 12 hours after you've had that steroid, you're going to start feeling better. And that's going to last you about a week. And by the time that week is gone, the virus is gone. So you're well. And then on the off chance that it is bacterial, the antibiotics will kill it off. But really, all you probably need is the steroid to make you feel better. And you're just going to treat the signs and symptoms. Rhinosinusitis then is sinus infection. I don't know if you've ever had a sinus infection. They cause a lot of pressure in your head. Anything that blocks the flow of secretions out of your nose is going to increase the likelihood that you get sinus infection. So you can have polyps in there. You can have trauma from diving too deep, flying too high, swimming too deep, those kinds of things. If you use and abuse nasal sprays, that can also cause inflammatory processes and scarring that are going to end up making you have more sinus infections. And there's less air sitting out here in your sinuses, right? You don't really inhale air into your sinuses, and it's a hollow space. And so that also facilitates the growth of bacteria there. So you're going to have signs and symptoms like a cold, but you're also probably going to have more pressure in your face. You might have some ear pain. Your eyes might hurt a little bit. Maybe have more of a headache. People don't typically come to the hospital for a cold or for a sinus infection. So I do want to spend more time talking about pneumonia because pneumonia is a major cause of death. Pneumonia is what killed people who had COVID. It's what kills people who get the flu. You know, we have lots of people in our world, not so many dying from COVID anymore, but from pneumonia. People die from pneumonia, die from the flu every year. Yeah, it was part of the hoopla when people were trying to decide whether or not to get vaccinated. It's like, well, you know, that many people die from the flu every year too. And they do, but if we can prevent it, we want to prevent it. You can get pneumonia because you've inhaled something. You can get pneumonia because you had a bad infection in your liver and it translocated up to your lungs, or it can also spread through your vascular space. I guess the things to know about this is that pneumonia is classified lots of different ways. It's classified as gram-negative or gram-positive. Y'all probably learned about doing gram stains in your micro class or in some kind of class, so that's what it is. Either it stains positive or it doesn't. It may be opportunistic, and opportunistic means what? That somebody's immunocompromised. Like which shouldn't typically make the person sick, but because their immune system is a bit suppressed, they're going to get lots of different other kinds of infections. It's commonly caused by the flu, and again, so when y'all go to clinical next semester, everybody that's in the hospital when they get ready to leave, especially if they're up over about 60 years old, 65 years old, the hospital's gonna try and give them a flu vaccine before they leave. Because, that's what happens, people get the flu and then they get pneumonia and they die from the pneumonia. Risk factors, we already said old people, elderly, immunocompromised, people who don't have good mobility, people who have other, comorbidities, like they already have asthma, they already have bronchitis or something like that. Same exact things that, and I think we talked about this already, but if you remember how they went about deciding who to vaccinate for COVID once we got the vaccine, those were the high-risk categories. Well, they were high risk from getting pneumonia from the COVID and dying, so it's the same group of people here for risk factors. So basically what happens, y'all, is you get an infection in your lungs. You know, the bacteria is gonna get in there somehow, and it's gonna cause an inflammatory response. So now when you think about that swelling that you think about coming out under your skin, now that's dumping into your lungs, that fluid. And so if you've got fluid dumping into your lungs, you're gonna block the ability of, you're gonna create a shunt. There's not gonna be any exchange of gas. And so the patients end up hypoxic. They have lots of chest pain because of it. So the signs and symptoms of pneumonia, y'all, they're a cold, jacked up, worse. You can have muscle aches and pains. You can be disoriented and confused. You can get dehydrated. Your ears might hurt. That chorea, that means the signs and symptoms of a cold. So, you know, cough, sneeze, achy fever, that kind of thing. A big thing that happens with pneumonia, let's see if it's up there. It's not even up there, but patients will also report that their chest hurts. Like it really hurts my chest when I cough. It hurts me when I move because there's an infection. There's some inflamed tissue, you know, wherever the pneumonia is. So we don't want to get down to, you know, cyanosis, that kind of thing before they get treated. Typically, these folks come in, they'll have a fever. They'll say they have a fever, they have chest pain, and they've got signs and symptoms of a cold. It's typically what happens. They're gonna get a chest x-ray. By the time they are feeling bad, there should be something showing up on the chest x-ray, and they'll get placed on antibiotics and hopefully get to go home. If they are dehydrated at the time that they come in, or their oxygen saturations are pretty low, they'll put them in the hospital and give them their antibiotics. And their the antibiotic that's chosen is gonna be based on what your organism is, basically. It's what all that gram stain business means. They should have an elevated white count. And then to take care of it, we kind of said that already, they're gonna get some antibiotics, and support them. Signs and symptoms relief. Okay, tuberculosis. Tuberculosis doesn't happen that much anymore, thank goodness. It doesn't occur very often. If it's going to occur, these are the categories of people that it's going to occur in. People that are immunocompromised, so that might be, you know, your transplant patient, your cancer patient, patients that have are taking steroids, like a lot of these respiratory diseases that we talked about today, those patients get steroids for treatment, and so that's gonna predispose them maybe to developing TB. It's also very common in folks who we say are institutionalized, but what that means is if you live in close quarters with a lot of people. So you live in an apartment with 15 people. You're in prison. You're in a group home. You live in a dorm that's got, you know, big open areas, so that wherever lots of large groups of people can come together in enclosed spaces. It's very common to occur in folks who are homeless, who are alcoholic, or who are malnourished as well. Those are the big categories that we've talked about. I wouldn't worry so much about silicosis. I wouldn't ask you about that. DM is diabetes. So this is what happens. That mycobacterium gets into your lung, and then your body tries to ward that off, and it forms this caseous-like waxy-like covering around the bacteria. And those little bodies now that develop, that are bundles of the bacteria with this waxy-like substance on it, they're called GON, G-H-O-N, GON complexes. And so it's hard to get rid of that bacteria because it's got this nice waxy coating on it that prevents, it's hard, doesn't 100% prevent, but it makes it very hard for antibiotics to get in there and kill the areas that are there. So it's going to be a chronic inflammatory condition, right? Anytime you've got bacteria, you're going to have that inflammatory process that goes out there to try and clean it up. And the thing that's bad about TB is that it's so hard to kill that this lasts for a long time. And the longer that it lasts, the more destruction of healthy lung tissue that you get and the more scarring that you get. So the telltale signs and symptoms are there you see low-grade fever, night sweats, chronic, progressively productive cough. With the interstitial lung diseases, they cough and cough and cough and nothing comes up. But if you have TB, you cough and it's a lot of thick green or yellow mucus. Lots of coughing and lots of production with that. Folks are gonna lose weight. They're gonna develop crackles. They're gonna have headaches and chest pain and all that kind of thing. But that low-grade fever, night sweats, and a chronically, progressively productive cough are the telltale signs of TB. Those are the ones that I would try to focus on. And to diagnose it, the first thing that's going to happen is a person's going to get a TB skin test, and you all have to have your TB skin test. If y'all haven't done yet, if you haven't, you need to get them done because you can't go to clinical next semester without them. So if a person is suspected of having TB, the first thing they're going to do is get that TB skin test. If it's positive, then they're going to do an X-ray. It seems like y'all just jump right on ahead and do the X-ray. On the X-ray, they're looking for those GON complexes. They're large enough that you can see those nodules in the lungs. If you have a positive TB skin test, it just means that sometime in your life you've been exposed to TB. It doesn't really mean you currently have it. So if any of you, maybe some of you did, you had a positive TB skin test, then what happens to you is you have to get a chest X-ray to see if you have active tubercular nodules in your lungs or not. So once you get out of school and you go to work, once you're working as a nurse or you're working in healthcare, you have a TB skin test every year. But once you are positive, you only have to have that chest X-ray. And how often you get that chest X-ray is going to depend upon the policy of the institution. Like here, if any of y'all had to get a chest X-ray for your TB skin test because you have a positive test, you don't have to get one every year. You just get it if you start getting symptomatic. You start having a cold or whatever, then they'll want to check to see if it's the reactivation of the TB. They do that skin test or chest X-rays. This is important too. These 3 consecutive morning sputum cultures. So that means first thing in the morning when the patient wakes up, they rinse their mouth out with some water, and they cough and they spit their sputum into this trap, and they're looking to see if they can isolate the organisms in the lab. Folks that have TB, they get put on isolation so that nobody else in the hospital gets it. Once you are diagnosed with tuberculosis, you're probably going to be taking rifampin, and there's another antibiotic that starts with an I that the name is escaping me right this minute. And you're going to have to take it for like a year. But the thing about TB is if you are thought to be not a compliant person, you can be required by the courts to have to go somewhere and take your medicine every day for somebody to see you do it. Maybe the CVS drugstore, maybe the preacher at your church, somebody is going to be responsible for making sure that you take your medicine, because it's very common that folks that have tuberculosis get very non-compliant because after a month or so and you start feeling better, you start thinking you don't need that medicine anymore, but you have to take it if you want to get rid of it. Okay, and the last thing we have to talk about is pulmonary third space disorders. So what do you think a pulmonary third space disorder means? What's third space with fluids? Yeah, it's right. So it's in the third space, in the interstitial spaces of the lungs. and it's a collection of fluid there. So we're going to talk about different kinds. We're going to talk about, for example, pleural effusions, pneumothoraxes, and hemothoraxes. So a pleural effusion is a collection of fluid in between the lung and the pleural space. It's outside the lung, but contained within the pleural sac. And so it can be different kinds of fluids. It can be transudative fluid, which would be fluid that is coming from like heart failure or liver failure. It's clear transudative fluid. Then you can have exudative fluid that comes from places that are high in protein. And you can have empyema, which means it's pus. So empyema means pus in the lung. That's one that you can't really look at and tell exactly what it means. So it's one we like to ask you about. Empyema means that you have pus in the lung space, in the pleural space. So, you have the meaty part of your tissue of your lung, and then you've got a pleural sac around it. So we're talking about stuff that's collecting between the sac and the tissue part of your lung. For pleural effusions, you can have, one type would be a chylothorax, and that is just a collection of lymph fluid. You could have a hemothorax, which is a collection of blood. So we're going to talk a little bit about a pleural effusion now. So with a pleural effusion, you're going to have, for whatever reason, increased hydrostatic pressure in your tissues in your lung that's going to force fluid to the bases where it's going to accumulate. That's what a pleural effusion is. If it becomes infected, it's going to be empyema. If it's not infected, it's just a pleural effusion. Pleural effusions, they happen like a lot of times in people who have other lung disorders. Maybe they have lung cancer.
Could you explain the hydrostatic pressure one more time?
So hydrostatic pressure is the pressure of water. So if you've got an inflammatory condition going on in your lung, you're going to get that capillary leak. It's going to make fluid leak out. That is hydrostatic pressure.
Okay, so in this circumstance, it's like, would you explain it like in this, like for this?
What you said for it originally.
Let me back up. I don't remember exactly what came out of my mouth.
That first line.
Like how
So anywhere that you have inflamed tissue, just by definition, you've got more fluid in that space, so you have to increase the hydrostatic pressure there. So like if you talked about smacking your thumb with a hammer and it swells up, you have increased hydrostatic pressure there because you've got more water there. It leaked out of your vascular space, and now that fluid's in that interstitial space. So in the case of your lungs, if you've got an inflammatory process going on, same thing's happening, you're still getting that might have been a test question, but it's non-specific inflammation, it happens the same no matter where it happens in the body. So you've got this fluid leaking into your lungs now, so you've got more liquid contained in your lung spaces that used to be in your blood vessel space, so now you've increased the hydrostatic pressure in your lung space. And then that tends to make the fluid want to get out of that space as well.
So that's in the plural?
Plural,
Of the lung space?
yes. In the functioning lung tissue, it's not the airways, it's not the blood vessel spaces. And so it's going to force that fluid out, and because it's fluid and it's gravity, it's going to tend to settle in the bases. I guess if you're completely laying on your back, it would be on the back part of your lung, but usually they occur in the bases of your lungs because most people, are able to be upright. Or we crank up the heads of the beds and make them upright if they're not. So people might or might not have signs and symptoms of a pleural effusion. This is what's happening between the pleural sac and the meaty part of your lung. Fluid's going to build up. So depending on how big it is, it's going to determine, are they having chest pain? Is that chest rising and falling, or both sides rising and falling? Can you feel that fremitus? Can you hear any kind of resonance? So how big it is really is going to determine if you have any signs and symptoms or not. If it's very small, it might go completely unnoticed. If it's bigger, you're going to start having problems. So you can imagine, let's say, maybe you've got a pleural effusion that takes up this much space. Well, heck, by now, you should have really bad O2 saturations, right? If it's just this little bitty corner down here, you probably won't even notice it. So it all is going to depend upon how big it is. fluid is dull when you percuss it, right? So you shouldn't hear dullness out of your lungs if you're not on top of a rib, unless there's fluid or a solid mass there. Anywhere, so what's happening here is, as the air or the fluid, whatever's filling up in here, it's compressing this lung, or collapsing is the word people like to use for a lung. It's collapsing the lung. So you can see that again, if like from here to here, that's a lot. This side of the chest might quit rising and falling. Because most of the respiration happens right down here in the lung anyway, you're gonna start to see that, so that's from this lung. This side's not gonna rise up as high as this side already, even with that much space, having that much of your lung compressed. And that really is the problem with these effusions, and when we talk about hemothoraxes and pneumothoraxes, is that the tissue that does the lung, the part of the lungs that does the breathing part's being collapsed, so there's not much breathing, not much diffusion and perfusion on the side where the pleural effusion is. You saw elevated heart rate there. So anytime we're not oxygenated well, our heart rate's going to pick up. We're trying to get more blood and more oxygen out. Oh, I'm sorry, got my back to you.
What does freedomus mean?
Fremitus is feeling like you can behind. I think it's on the air move. So to treat, did you have a question too? Oh, okay. Tactile fremitus, you can feel it like, you'll do this thing, I think you still do it, like 99, I can't do my jean jacket, if I had my hand on my skin, I'd be able to feel the vibration there. So to treat a pleural effusion, it depends. If it's not too big, they'll leave it alone. If it's big, they're going to pull the fluid off, and that's what a thoracentesis is. They may leave a drain in. If they think it's going to continue to fill, they'll leave a drain in. They'll look at the fluid to see if it's infective or not, so to determine whether or not you need antibiotics. And then, of course, they can do x-rays to look and see if it's getting bigger, better, or worse. Okay, a pneumothorax is like a pleural effusion, except that it's going to be a collection of air. It's not liquid, it's just air. So there's a couple different kinds of pneumothoraxes up there. The first one you see up there says primary. That is something that's idiopathic. It just spontaneously happens every now and again, and we don't really know why. We do know that it happens more often in young Caucasian males. That's the group that it happens the most in. So just spontaneously.
You said that's primary.
Primary, yeah, it's unknown. Primary, it's like primary pulmonary hypertension, primary polycythemia. Primary usually means it's a disease of that organ itself. We don't really have any, it's not secondary to anything else. Secondary pneumothorax means that there's probably some kind of underlying problem that's caused it. Maybe they have lung cancer, maybe they've got an abscess in their lung, but there's some other kind of this is occurring secondary to another disease process. And then a traumatic pneumothorax means that there's been some kind of penetrating trauma to your chest. Knife wound, you've gotten impaled on an object, there's a gunshot wound. Maybe you're the picture on a baseball team and a ball comes back at you hard, it hits hits a bone, a rib, and it pokes a hole in your chest. Those are traumatic ways that you can get air into your chest wall. A tension pneumothorax is probably the worst one up there because with a tension, so if I get I need to look at my slides and not get too far ahead of what I'm saying. So if I get a gunshot wound in my chest and it makes a hole, and so when you breathe, you suck air in. That's called negative pressure. Suck air in. And then when you exhale, you blow air out. So if I've got a hole here and I suck air in, but it's like a flap instead of a true hole, and it closes, I can't blow the air out. But each time I breathe, I suck in a little more and I can't get it out. Suck in a little more, I can't get it out. So eventually, whichever side that's on, it's going to completely collapse this lung. And it can shift things over. So that's the worst one, because that one will kill you pretty quickly. And then iatrogenic just means that it happened in the hospital, probably, well, it happened at the hands of a healthcare provider. It doesn't have to be in the hospital, but chances are there was some other kind of medical procedure going on. Maybe they're putting in a central line is very common, and they did it, and the pneumothorax was caused by that. So a pneumothorax happens because there's a hole in that pleural sac, and it allows air to come in. So they typically, if you have a pneumothorax, the air typically is going to collect up top, right? Because it's air. Air is going to rise to the top. Remember we said fluid's going to settle to the bottom in your lungs, but air is going to rise to the top. And I kind of have said that already. So as you inhale, you suck air in. But if it's a permanent hole, at least I get to blow some of it back out, and so not as much of my lung is going to collapse. So your lung is going to collapse, and then you're not going to have gas exchange there. You'll learn when you're in the hospital that whenever a patient gets central lines put in, as soon as the central line's put in, the nurses typically, they're in the room, they put their stethoscope on and listen to make sure they can hear air moving on both sides. Because if you, we call it drop a lung, if you get a big pneumothorax, that whole lung's just gonna collapse and there's not gonna be any breath sounds over there at all. And they'll also get a chest x-ray. Kind of already said this, if it's a secondary pneumothorax, it's probably because there's some other disease process going on in the lungs that has weakened your lung and allowed that to happen. And we already defined what traumatic meant too, didn't I? Yeah. So the ultimate thing in all of these pneumothoraces is that the lung is going to collapse. It's going to compress that meaty part of the lung and you're not going to have any gas exchange. And this is where I should have looked 4 or 5 slides ahead, because this is when I was talking about attention pneumothorax. The only thing that I really didn't say that I kind of stopped there is that, so let's say I have a tension pneumothorax on this side, and my heart's sitting right here, right, in the middle. It's not over here on the left, it's sitting here in the middle. So as this lung gets compressed, and the pressure builds, it can make my heart go like this. And so if it pushes your heart over, it's going to clamp, it's going to shut off the blood flow from your aorta into your heart. So how long do you think you'll stay alive like that? Not long. So for folks that have a tension pneumothorax, or if they have a pneumothorax at all, you really want to be watching out for this tension business. And if that happens, what you're going to start to see is that their trachea is going to get pushed off to the side, right? Because your trachea is also here in the center of your chest. And so if this lung is pushing, if I've got a big pneumothorax on my right side, it's going to push my trachea over to my left side. If y'all remember I told you about my nephew that had the CML, and that part, so the bone had dissolved in his neck. He went to surgery, and so he wore a helmet and a brace on his neck for quite a while. But his dad, my brother-in-law, said that he noticed that his trachea was way over here, almost pushed back to his ear, he said. And so he told somebody that was in the nurse or the doctor, and so they had to rush him down and put a chest tube in him because he was fixing to do that. And it happened from the surgery. They were doing surgery up and around his neck, and somebody nicked a lung and didn't realize it, and caused him a lot of trouble. Okay. Do y'all know what contralateral means? So, if the injury or the problem's on the right, the contralateral is the left. It means the side opposite of. So that's a fancy word for the opposite side, I guess. And so your signs and symptoms of a pneumothorax are going to depend upon, the severity is going to depend upon how big, how much of the lung is collapsed. But you can imagine that they're going to be very short of breath, they're going to have chest pain, they're going to have anxiety, their heart rate's going to pick up, and they're going to have signs, quickly developing signs of respiratory failure, respiratory distress. There will be no breath sounds or no chest movement where that is either, because there's not, the lung tissue is going to be collapsed, so it's not going to be expanding and contracting, right? So you're not going to have any movement on that side of the chest, and you're not going to have any breath sounds on that side of the chest, which is asymmetry of the chest movement. If the pneumothorax is small, then, may not do anything about it. If it's big, they'll put a chest tube in and until all the air is expressed from the lung and the hole can seal itself. A pleurodesis is, y'all think I have a tear. I think my family's very healthy, but I keep telling you about all these people in my family. I have a nephew whose wife, she's a thin white female, so she wasn't male, but she met the other categories, right? And she's had 2 spontaneous pneumothoraces, so they did a pleurodesis on her, and what happens is they put it's a powdery like glue, and they put that in when you have the pneumothorax. And they don't usually do it the first time, but they'll do it on a subsequent one. And so what it does is it sticks the meaty part of your lung to your chest wall, so you can never have another pneumothorax. So they don't usually do that the first time a person has one, because it's kind of a rare thing anyway, but if you demonstrate that you have these on more than one occasion, they'll do that. And say it sticks the chest wall, the lung, the meaty part of the lung to the pleural sac, and so it can't collapse anymore. And that's what that is. And then a hemothorax is, the process is the same. Part of the lung is gonna collapse because the space is gonna fill up with the blood. Here, the blood's gonna be in the bottom part of the lung. The signs and symptoms are gonna be very similar, right? The patient's gonna be real short of breath and anxious and have chest pain. They may have a falling hematocrit and hemoglobin, they probably will, because they're losing blood into that third space of the lung there. And the treatment's gonna be the same thing, to put in a chest tube. They may have to go to surgery if there's a major vessel in the lungs that's bleeding. And they're going to drain that blood off so that the lung can expand and collapse and they can breathe adequately. I'm hearing it sounds like church and everybody's getting their keys out and we're ready to go. So I think that must be the last slide. So y'all don't forget you have skills this afternoon, okay?
I downloaded these from last week. Is this going to be next week or is this first? This is just Canvas. I downloaded it all. I downloaded it.
Well, I just did it on Thursday, so it's already set. All of those lectures are recorded, so we go short with we did like short 20-minute videos, so it's really the same thing.
Okay, so we don't need that.
Well, you can look at it and do the same thing we just did in class, it's just separated out. So that you don't need, it's the same thing.
It just,
So what we did is we broke it down into smaller, PowerPoints, nobody wants to see them 3 hours, so it's the same thing.
and he's like, what are you doing?
Every now and again, Dr. Swansea and I have to miss a class, or there's a program or something that we posted, so recorded lectures, and just make it left over from the semester.
I was trying to look up your schedule that you put, but I didn't go into notification. I was like, I didn't find it something.
So if you go and look, when you go to the opening page of the class, there's one of the first page there, it says, the sandwich with Dr. Mike. You